Hey, Omies, welcome back for another episode on the I Believe podcast, your number one source of information on ocular melanoma and the latest and greatest in research. Today, I am joined by Dr. Amy Scheffler, returning to chat with us about what's new in radiation retinopathy. So, Dr. Scheffler, thanks so much for being here today. We are thrilled to have you back. Can you just talk to us a little more about these modern approaches that we're seeing to radiation retinopathy today?
Thanks so much, Jeanette, for having me. It's great to be back. And to connect with your audience. In terms of radiation retinopathy, it's actually been a pretty long journey to get where we are. Intravitreal injections, meaning injections of medications that are done through what's called the pars plana, which is kind of the safe anatomy right in front of the retina, to deliver drugs to the back of the eye and the retina, have been done pretty much routinely in the United States since about 2004. So it's coming up on 20 years of experience with that. The journey of how we got from there to here is kind of interesting and relevant. So these drugs were used first for much more common diseases, certainly than radiation retinopathy, diseases like diabetic retinopathy and macular degeneration. And the kind of journey that these injections took from kind of early generation drugs that didn't work all that well to better drugs to the drugs we have today has been, kind of an incredible one and really an explosion within retinal medicine and ophthalmology in general, and honestly, medicine in general. For a couple of years when these injections first came out, nobody was really using them for radiation retinopathy, of course, because radiation retinopathy is a rare disease. Over time, it kind of dawned on all of the ocular oncologists around the US and around the world, we should think about translating some of these for this disease as well, because there is certainly some overlapping biology with diseases like radiation retinopathy. Avastin or bevacizumab, you can think of kind of like an off-label generic drug within this most common class, the anti-VEGF drugs. People started experimenting with that for radiation retinopathy probably at least 15 years ago now. And there have been kind of a handful of retrospective studies published 15, 10, 12, 10 years ago, kind of looking at the use of Avastin for this that were certainly kind of suggestive that it was helpful, but certainly not kind of definitive in a sort of prospective, definitive way that we expect from high-quality medicine. Over the last 8 years or so, there have been a handful of small, what are called ISTs or investigator-sponsored trials looking at what we call on-label or FDA-approved drugs, again, for more common diseases like radiation retinopathy, being used for radiation retinopathy. And we did a couple of those trials, and other centers around the country have done them. Ivana Kim was really a trailblazer in this. And that data was also very suggestive with several drugs that they were helpful at slowing down the rate of vision loss in our patients who'd had radiation, either for uveal melanoma or for other orbital tumors as well. This is all leading up to a brand new multi-center prospective huge scale trial being sponsored by the DRC or the Diabetic Retinopathy Clinical Research Network, which is a huge multi-site network across the country that's been doing trials in diabetic retinopathy for probably 30 years now. And they started expanding to other diseases other than diabetes several years ago, and this was kind of one of the interesting diseases they were interested in working in. So this is a huge trial that's currently enrolling across the country at many, many sites across the country that is hopefully going to be pretty close to as definitive of a study in this disease as we've had so far.
Okay, so you mentioned some of the research that Ivana Kim had done around like the drugs and that are helping with radiation retinopathy. Do you have any kind of specific studies that we could reference?
Ivana was really the first person to publish a large prospective study looking at an on-label anti-VEGF agent for radiation retinopathy. And of course, I'm sure many of your listeners know that when we think about research and data in this disease, or really anything in medicine, in particularly clinical research, there's a real emphasis on prospective data. Prospective data is way more powerful and validated typically and predictive than retrospective data. Meaning if you take a bunch of patients that you've treated over the last 10 years and just kind of go back and look at their charts and say, oh, hey, let's see what happened, you can definitely glean a lot of information from that kind of approach and learn a lot. But because patients weren't treated in a rigid way, every patient the same as the next, when their treatment started, when their treatment finished, what criteria were used to treat them or not treat them, you end up with this very heterogeneous kind of mosaic of patients. And that limits how strong the conclusions are that you can draw. In a rare field like ours, we often have to draw conclusions from heterogeneous kind of mosaic retrospective data, but ideally we have prospective data.
Prospective meaning it's something you're planning to research in the moment in real time.
Exactly. So you say to yourself, here's our study design. We want to study X scientific question. Any patient who comes in the door who meets very specific criteria that we set, diagnostic criteria, we are going to offer them the opportunity to enroll in this study. Usually it's a randomized design where patients get randomized to either, let's say, treatment or sham or placebo, or perhaps get randomized to two different types of treatments, or sometimes it's multiple treatments and placebo. And then you follow those patients with predefined endpoints moving forward. So the whole entire design of the trial is already set in advance. And that creates a situation where the power of the science is significantly greater than retrospective studies. It's all kind of a scientific model that's been, developed for decades and is highly validated. And all FDA-approved medicines in the United States are required to go through a rigorous scientific process like this. So there are a handful of these drugs that have gone through this rigorous prospective process for other diseases in the retina, like diabetic retinopathy and macular degeneration. And Ivana was the first person to really take one of those drugs and say, hey, okay, I'm going to look at this in a prospective fashion, but for this disease with any kind of significant number of patients. And so she published a study looking at a drug called ranibizumab for radiation retinopathy, I think 40 patients in around, I want to say 2017 or 2018, showing essentially that when she compared her data to the natural history of these patients, meaning how quickly and how severely patients lose vision after having undergone plaque brachytherapy, it certainly seemed that the patients who she was treating with injections did much better in terms of the amount of vision that they were able to retain over the 2-year course of her study. These trials are a huge undertaking, even just for 40 patients. It's a massive, massive amount of time and resources and commitment and staff and patients. And so, it's really a huge accomplishment on her part.
Oh, that's incredible. I would love to see that study, and I would love to make sure that we can link that in the description for our listeners, absolutely, so that, you guys who are listening, you can go and you can read about this and you can see how this kind of a study works. So you mentioned a little bit more about like the anti-VEGF. Can you define the difference between an anti-VEGF medication versus like using laser or steroid as a treatment for radiation retinopathy?
Prior to the era of anti-VEGF, there certainly were clinicians around the country who were trying both lasers and steroids for radiation retinopathy. And that was partly because, again, those were the mainstays of treatment for other diseases, more common retinal diseases, like at that time, like diabetic retinopathy, and even to some degree, macular degeneration, and certainly retinal vein occlusion. Laser is a treatment that's mostly done using a headpiece that has a light that's emitted from it, that's transmitted through the pupil, non-invasively without instruments or cutting or anything like that, but non-invasively through the pupil. And then that laser energy is absorbed by certain layers in the retina that creates ultimately over time, for initially inflammation and ultimately a scar. Retina that is ischemic, meaning it doesn't have good blood flow, has various biological drivers to result in what's called neovascularization, which is essentially this drive to create new blood vessels, right? You kind of have retina that's dying off that says, I'm not getting oxygen. I think I'm going to grow my own new blood vessels, right? And it grows these sort of abnormal networks of atypical blood vessels that don't function for the purpose that the eye wants them to. They don't really revascularize the retina effectively, and ultimately they end up in all sorts of problems like bleeding and fibrosis, which is scarring, and ultimately retinal detachments and even blindness. And this is a kind of a pathologic process that we see in diabetic retinopathy. We can see it in retinal vein occlusion, and we can even see it in severe radiation retinopathy. The concept of anti-VEGF medication is actually to lower the biological drivers that make that ischemic retina, that retina with no good oxygen, to make it stop having that drive to grow those abnormal blood vessels so that you won't have those bad outcomes.
So basically telling it, we know you have this impulse to do this, but we're going to shut down that impulse.
Exactly. Steroids can be given in the eye in many different ways. You can actually give a patient steroid pills, as many people know, and that will penetrate the eye to some degree. You can use steroid eye drops. You can give steroid injections around the skin of the eye that sort of passively absorb into the eye. And you can even give steroids injected directly into the eye. And steroids are good at essentially having a very powerful anti-inflammatory property, just essentially completely across the board. It's almost like an atomic bomb that just destroys all inflammation. And steroids can be extremely effective for both diabetic retinopathy and radiation retinopathy. They don't often address in a sustained fashion that thing we just talked about, that drive to create those abnormal blood vessels. Some patients with radiation retinopathy actually benefit from both types of approaches. Some patients benefit from one, some patients benefit from the other, anti-VEGF or steroids. And part of what the DRCR trial is going to address is, okay, which is better, in what situation, which patients benefit from one or the other.
Let's just chat briefly about the DRCR trial. Let's run through the NCT number for the National Clinical Trials. We'll link that as well for you guys listening. But can we just talk a little about like the criteria to qualify? Maybe just the things that patients listening who maybe haven't had their eye treated that should know they go into having their eye treated with brachytherapy.
an average patient who is diagnosed with uveal and undergoes brachytherapy or proton beam radiation. All of these modalities cause radiation-induced damage to the retina. Much of the detriment to the retina, much of the damage is caused through damage to the blood vessels in the retina. And the blood vessels are necessary to maintain oxygenation of the retina, and the oxygenation is critical so that the tissues kind of function in a normal way. So what happens at the time of radiation is that the radiation penetrates the retina, which is overlying the choroid, and essentially is hit with sort of like collateral damage. And then the blood vessels, particularly the lining of the blood vessels, is damaged. There's a cell called the pericyte, which lines the inside of the blood vessel, and those pericytes, as they become damaged over time, they kind of degrade and stop functioning. And when you don't have good pericytes lining the blood vessels become non-functional. Many things happen to them in a very complicated cascade, but to sort of oversimplify it, those blood vessels become leaky. They can't kind of retain the liquid in them that's supposed to stay there. And so a lot of that fluid leaks out into other layers of the retina, which, if we're talking about the center of the retina, essentially makes patients' vision blurry, right? Think about like looking through a swimming pool. You don't want your retina swollen with fluid. And so the concept of anti-VEGF medication is to kind of lower those inflammatory drivers, those biological signals, to have inflammation, to have leaky blood vessels so that the retina dries up and then the image that the patient sees is sharper. In a regular clinical situation where a patient gets brachytherapy, most of the time they don't lose all their vision immediately. That damage happens slowly over time as those pericytes and other cells in the retina die off. On average, patients may have a clinical drop in their vision 2 to 2.5 years after treatment. Again, highly variable depending on how big the tumor is, where the plaque was placed, how strong the plaque was, and so forth, but on average, although we can see evidence of the damage much, much earlier on our imaging. I would say in the average ocular oncology clinics, certainly in the US, patients will often get injections for this, kind of not immediately when they get their treatment, but later down the road. Some centers start the injections even sooner, like before there's vision loss. The DRC are design what a lot of my colleagues like to call a prophylactic design. So patients decide that they want to enroll in this trial before the time of their brachytherapy. So they've kind of already made a commitment to the study. And so enrollment happens, or certainly the screening visit happens before the patient actually undergoes brachytherapy. So it requires certainly planning on both the investigator's part and the patient's part. And then the patients undergo their first injection of either a treatment or a sham within a very short time after the brachytherapy. So the treatment starts essentially immediately right at the time the radiation is done, with the intention of trying to essentially prevent those biological changes that we talked about, or certainly delay them.
So then is the aim of the trial to prove, or to try to, I guess, prove whether or not it's helpful to start these anti-VEGF medications really, really soon after brachytherapy versus just waiting for a couple of years?
Yes, correct. So the protocol design committee, which I was grateful to be a member of, we had lots and lots of debates and discussions behind the scenes for probably close to 1.5 years about, when do we start? Do we start immediately? Do we wait? And I think the feeling of many of the folks on the committee was, hey, let's really do this in sort of as definitive and aggressive a way as possible. We think we're going to get a bigger improvement in patients' outcome if we do it earlier rather than later. So that was the reason for that approach. I think the study's not comparing that approach to an approach in which patients get injected later. So you won't have exactly a head-to-head. But certainly if this study shows definitively that there is a significant improvement in patients' vision with this approach, I would imagine that will be something that will be adopted by many clinicians who take care of.
No, I think that's so important. And I love that you talked a little about how this is a process that in order to consent to this trial, you do have to make sure that you haven't actually had brachytherapy or proton beam therapy, because I think that that's one of the things that once we enter the treatment space as patients, I think that a lot of our listeners can probably relate to this, that we kind of go into it just expecting that we're just going to have gotten all of the information that we needed from the get-go. And sometimes trials like this get, slipped under the radar, or they just don't really get talked about as much. So I'm really hopeful that as we have some newer patients who are newly diagnosed, haven't had treatment yet, that they'll be able to consent to this study, just be a part of this, just to see, does it help? Because, I guess the way that I would think about it is, best case, it does help and it helps preserve vision for longer. Worst case, it doesn't do anything different than would have happened already. And like you said, that's kind of the end result of any radiation to the eye, is that there will be some level of deterioration. We just can't say exactly how much. Because like you said, that's subjective to the size of the tumor, to where the tumor is. There's so many factors.
That's right.
What would you say would be some of maybe the hesitations that patients might have to participating in this trial?
I would say these injections are very safe. I should say that up front, in that truly millions and millions of patients around the US and the world have undergone intravitreal injections since their introduction in the early 2000s, as we were saying. And the particular two drugs that are being used in this study, faricimab and fluocinolone, have also been, FDA approved for various other indications and have been used widely. So it's not, I think it's important for patients to understand, it's not, the drug itself is not an experimental drug. We already know the drug is safe. We already understand the pharmacology of the drugs. What's new here really is the application for this particular condition. So I don't think there should be any patient hesitation in terms of safety, but it's really more, I think, a logistic thing. So this trial, like every clinical trial, does require a commitment on the part of both the investigator and the patient. The patients in the faricimab arm get injections every 3 months. And so that's a pretty reasonably frequent commitment. I think particularly for our uveal melanoma community, many of our patients are seeing an ocular oncologist who's not necessarily right in their community. They may need to travel really far to see their clinician. Certainly, many of the patients in my practice come from very far, another state, 2 states away, 5 states away, even 15 states away. And so that's a big commitment to come every 3 months, particularly in a period of time where if you were just having regular clinical care, you really might not be coming that frequently. That's, I think, the biggest barrier. I think that'll be overcome. There'll be patients who are super motivated, and there'll be patients who happen to be lucky enough to see an ocular oncologist who's in their community. That makes it more doable. The other thing that's important to understand about clinical trials, and this is not just true for this one, but for all clinical trials, is that the funding for the medical care that patients receive in the clinical trial, so the examinations that are part of the trial, the medicine that's given in the trial, all of that is funded by the trial. This particular trial, again, is funded by the DRCR, as well as by some of the drug companies who are providing the drug. So all of that burden does not fall on the patients, and that's pretty standard.
Yeah, that's super good to know. Some trials offer travel. Do you know if this trial offers any kind of travel compensation for if patients do have to travel for the treatments?
That's a great question. I don't think it does.
It's always just good to know. Sure. And then also to look for other avenues of financial aid, because those are out there as well.
For sure.
Just through Ocular Insight, we do offer financial aid for qualifying patients. And then we've got various other sources of travel function financial aid that it's, specifically to help you to travel. So if you guys have questions about that, please reach out. We would love to help you make sure that you can get to something like this or to any kind of a trial which would necessitate you traveling somewhere else. Did we talk about the NCT number?
So it's 058-44982. So I think, for all patients with a rare disease like it's important to kind of be familiar with the clinicaltrials.gov site, right? So that's the, NIH's National Library of Medicine sponsored database for all monitored clinical trials in the United States. Essentially, all legitimate peer-reviewed studies. I was going to say prospective, but there are actually retrospective studies in the clinicaltrials.gov database too. But certainly all prospective interventional trials and many retrospective trials are essentially registered through this process on this website. And there's a search engine where you can search for, what are all the clinical trials that are happening in the United States about radiation retinopathy or about, for metastatic uveal melanoma. And that's really the home where all of these live. It's a huge service to patients. If you go to clinicaltrials.gov and you type that NCT number in the search bar, the study will come up.
Okay, so just for those of you guys listening, I'll say the number again, 05844-982. And we'll link that as well as the direct link to the clinicaltrials.gov area in the show notes, as well as the description. You guys can find that in the YouTube and the Podbean, like any of the podcast listening channels. But for you guys, if you just want to go ahead and type it in, that's what the number is. So you can see that in the description. What would you say is the thing that you're looking forward to the most with this specific study?
what's so exciting about it is that it's going to be done on a very large scale. There are going to be a significant number of patients in it, and it's going to be done over a long period of time. And so what that does when you have a huge bulk of patients and a long study period is it just creates very meaningful and significant data that can really guide us in terms of what is best for these patients and long-term, what's the best approach to take to help them preserve their vision for as long as possible. Dan Martin, who's the chair of the DRCR, have been very instrumental in being motivated to do this. Many of us had been talking about this for many years, but it's something on a very large scale and difficult to do in a rare disease from both a funding and an organizational standpoint. So I think it's great to finally have arrived to a place where we're doing this. It is going to take a long time to get all the patients enrolled, get all the data, analyze the data, and learn from that data. So I guess what I would say to patients is be patient. There's lots of patients who are just going to get kind of typical clinical care as this study is evolving because it's such a long period and not every patient is going to be able to enroll in the study, obviously, for the reasons we talked about. But ultimately, long-term, it will provide us with really, really valuable data.
Oh, that's so exciting. All right. Well, you guys, this has been so exciting. We are absolutely going to have Dr. Scheffler back to chat with us again. So stay tuned for that next episode. But for now, I just want to say thank you so much to our listeners. Thank you to everyone who has hit subscribe on the YouTube or on our podcast platforms. And thank you so much to our sponsors. We've got Castle Biosciences, Delcath Systems, and Immunocore. And we are so thankful for you guys for making sure that this podcast is funded and that we are able to continue providing information worldwide to patients with ocular melanoma. So Dr. Scheffler, thanks so much. We'll see you back soon.
It's great to be here. Thanks.